Thank you, everybody, for your attendance to the Men's Health update for 2017. We've done a bunch of these in the past, but not recently. And so it's great to see our primary care friends show up for an educational evening. We are all Granger speakers, and this is put forth by Utah Healthy Living Foundation. We also could not do this without the supporters that you all visited. Thank you for that. So these are the three companies that extended a little bit of support. Just to briefly tell you about the Utah Healthy Living Foundation, our mission is to improve the quality of life in Utah through health education screenings. We organized ourselves in 2001. Actually, at least a handful of you know about our Bob Dole event in 1999. There were several of you participating with that. That was the moment where we decided we needed to raise our own money because the American Cancer Society wanted a big chunk of it. So we put this together in the hopes of future educational efforts. Thus far, we've had an entirely voluntary staff, so therefore we are 100% financially efficient. And in 2006, we obtained CME accreditation, which is how we can put this event on. We currently sponsor the annual Utah Urological Society meeting and others, and Peter Fisher led the Zero Prostate Cancer Run. We were a supporter of that, and then many other health screening events. So just in terms of housekeeping, obviously speakers, it's a CME event, have to declare their conflicts of interest, or their disclosures, therefore. On May 2nd, JAMA was an entire edition dedicated to conflict of interest. This is extracted from the lead article. Physicians should make informed, disinterested judgments, and it is incumbent to health professions to champion their reliance on evidence and disinterested expertise, and this is from Dr. Feinberg, the president of the IOM. We are accredited by the UMA, and we've got this program, therefore, approved for 2 hours of Category 1 CME. We are going to put this program online, and this comment is for those people who do it online. So I'm Steve Gange. I'm the co-founder and president of the Utah Healthy Living Foundation, and again, we've worked tirelessly to make this organization successful and impactful. I'm also the director of education for our Summit Urology group, and I have 25 minutes starting now to get you through this. So starting with my disclosures, and I have more than some, these two companies represent the two newest kind of kids on the block with respect to BPH procedures, and I've been very involved. I was the first in North America to perform both procedures. I've done a bunch of both procedures. You can see I was a principal investigator and lead enroller of both trials, second author in all the papers, faculty proctor, et cetera. I want you to know that because I am disinterested. I don't own stock. I'm not paid tonight to do this event, and this is purely a CME event. You are going to hear about the two products, and then there's some other things that are up and coming. I'm an investigator for something called NIMOX. We've got something called Procept, and we'll talk briefly about that, and then ZenFlow, and these are all BPH products. So to just start with a quick overview of the challenges of men's health, I love this quote from Mr. Huxley, that men do not learn very much from history is the most important of all the lessons of history. And we're talking about men. And I like this especially well because progress isn't made by the early risers, it's made by lazy men trying to find easier ways to do something, and this guy's sucking his spaghetti on his chest. So I have a relationship with a PhD men's health expert at UC Berkeley. I've learned a lot about men's health from him. And here's a few statistics that still are accurate. Men die in America 5 years younger than women, and interestingly, it was only a year younger in 1920. It so happens that married men live longer than unmarried men. We die more often of 14 of the 15 leading causes of death, except Alzheimer's, and are twice as likely to die from heart disease. 3/4 of the MI deaths under 65 are us, men. And we have a greater risk of serious chronic diseases and suffer from them at an earlier age. Some of that's our own fault. Because most of us believe that we rate our own health as very good, excellent, and we feel healthier than the guys we see, walking around us. We report fewer symptoms than women and are less likely to feel at risk for illness and injury. And if there is an injury, we spend a lot less time recuperating from it than women do. We perceive less risk from alcohol, cigarettes, drugs, sun exposure, unsafe sex, reckless driving. And we've seen in those areas some of the outcomes of that perception. Our organization, the AUA, American Urological Association, has we want to believe that we can be the men's health doctors, partly because people don't, if they come to see us, they sort of feel like they've got it covered, right? They've seen a doctor for the year. Well, we're not perfectly qualified, we understand that, but we at least want to know what men need in terms of health. And this list, and it's exhaustive, obviously, was put together in conjunction with some primary care physicians. And you see lots of things that men should be doing in the different age groups for their own health maintenance. And even further, health screenings, cancer screenings. Obviously, I can't even see this, but there's plenty of stuff that guys should be doing. But the problem is, and this is Andy's slide, men avoid doctors. And twice as many men than women have no regular source of medical care. We comprise 70% of those who've never seen a doctor or haven't seen a doctor in the past 5 years. And this is classic. 25% of men would wait as long as possible to see a doctor, like the bone is sticking out of your skin, And is this a matter of tolerance or simply fear? And I don't know the answer. But what I do know is this is the challenge of men's health. We have all kinds of things that we can do for people who actually come to see us, and of course, see you. So with that, June is National Men's Health Month. I'm sure we're going to fix this problem by wearing blue. So, I'm wearing blue. Awareness, prevention, educational, and family, and there's a lot of efforts nationwide. There was a drive. A couple of urologists have a Tesla. They drive across country every year to raise awareness for men's health. But guys have to listen. So we'll shift into the BPH update. I always think this is a totally inaccurate slide. It's published in a reputable journal, but I think that men experience BPH symptoms almost universally after age 50. But in terms of diagnoses, it's fourth on the list. It's about 10 times more common than prostate cancer. And, many, many studies have demonstrated this is a matter of aging. So BPH, both histologic and clinical BPH, increases with age. And you can sort of see in the 70-year-old age range, about 70% of guys have histologic BPH. Many of those have clinical evidence. We know from this MSAM-7 study from quite a while ago that older men, are still sexually active. It's important for us as urologists to recognize this. Some of the things we do creates problems in this area, but men still care, even into their early 80s. Now, this is also interesting because the same study demonstrates that there's an age effect in terms of sexual activity. So as men get older, of course, that decreases, but there's all these intervals or these individual categories. And with increasing lower urinary tract symptoms, sexual frequency declines. And we don't quite understand the relationship between BPH and erections, for example, but there is clearly some statistical correlation. BPH, so we really talk in terms of lower urinary tract symptoms because certainly they can be caused by other things, rarely by prostate cancer, but certainly strictures or all kinds of other things. And therefore, we subdivide it. We don't ask all these questions of our patients. We send them to the exam room with one of these checklists. So we do this AUA symptom index that does ask all these questions. This is a validated questionnaire, and we use it again and again, and we can see how patients progress or how they improve with our treatments. And left alone, BPH is still a bad problem. Symptoms will progress, infections can ensue, bladder stones can form. With enough of a degree of retention, there's pressure up into the kidneys, hydronephrosis and kidney failure. Elderly men have a higher risk of falls and fractures when they're trotting off to the bathroom at 3 in the morning. And bladder health, over time, absolutely declines. And reduced bladder health limits the treatment effectiveness down the road. Oftentimes, we see these guys, by the time we see them, their bladders are deteriorated. We start this evaluation based on symptom severity, degree of bother, And that initiates the conversation. We do a physical exam. Of course, we've done the IPSS, or the AUA Symptom Index. We do these bladder scans in the office. That's helpful. A digital exam is very important. Scott's going to talk about this shortly. Sometimes we need to move on to a little more invasive diagnostic test, and this is kind of what we get when we do a flexible cystoscopy. And it doesn't project super well, but you can just imagine the slot canyon that we're traversing up into the bladder. Most prostates are made of 2 lobes. Some have a 3rd lobe. It does matter in terms of our treatment choices, but this is a typical obstructed prostate. So then in addition, lab tests like a UA, maybe a creatinine if the residual's 1,000 or more, and a PSA when it's appropriate. And this is what we're left with. So we get these guys through this algorithm of treatment, or of evaluation rather, and now we start talking about treatment options. And most patients, and this is pretty current data, 12 million men in the United States presenting for some form of treatment, most patients are on drugs. And that's the list of drugs, and you know all these drugs. A bunch of the guys on watchful waiting were on drugs. They didn't like the drugs. They don't want anything else. They just go off to pasture until their bladders create problems for them. It's also very interesting, especially to urologists, that only 2 to 3% of men with treated BPH in this country elect our surgical treatments or thermotherapy. So the surgeries are listed. You know, we've made some advances in the last 85 years, but TURP is pretty much still a TURP. Transurethral incision we use for smaller prostates. We've done laser things. Sometimes we have to open a patient to remove the prostate. It's so large. And lately that's been done more robotically. In the early 2000s, these thermal therapies came along. We had microwave therapy. Many of you have patients who had microwave therapy. Some of them also may have had, instead of microwave, tuna, which was a radio frequency ablation, needle in the prostate, delivery of energy, heats the prostate. Both of these designed to kill cells by heating. And, you know, in many ways, they've kind of come and gone. And there are things that aren't on this list that definitely have come and gone. What we're left with now, in terms of less invasive things that are newly FDA approved, are these 2 at the bottom, and we'll talk about them. This is important, again, for urologists. I didn't know all this. Well, 2/3 of men being treated for BPH with a drug or on an alpha blocker, I knew that. 1/3 maybe on a 5-ARI, finasteride, dutasteride, or in combination with an alpha blocker. But what's really telling is the fact that we see less than 1/3 of those patients. Primary care folks, you know, you're the gatekeepers with respect to BPH. So hopefully through this conversation, you know, maybe that'll enlighten some opportunities. I always wonder, why aren't we seeing them? Is it because they're perfectly well? Is it because they don't want to see us, right? Or maybe the primary care doctor doesn't like what we do. Any of those things could apply. We've always been taught about 1/4 of men stop their drugs in a year, but this is a powerful study from Italy. 1.5 million men who were started on a BPH therapy, medical therapy, and only 29% adhered to that therapy at a year. Maybe because of lack of efficacy, side effects, cost. I mean, these are the reasons people stop these drugs. That study didn't really elucidate that. But I wonder what happens to these guys. And is their bladder dying? Detrusor decompensation, is it inevitable in a guy who was on drugs, doesn't like the drugs, and just kind of putters along until he goes into retention? And do we see them in time to save their bladders? So briefly, you know, the things that have been out there, most of you are very aware of, you know, surgery is well established, long track record. It's definitely effective. It's the most disobstructing thing we can do to the prostate. It opens the channel. We do that with either monopolar energy, bipolar energy. Sometimes we just melt the prostate with a button. We also have done a bunch of laser things, and so there are clearly advantages, but there's some disadvantages. General anesthesia or spinal, possible hospital stay, catheter of any length bothers our patients, and then a prolonged recovery period or a period of restricted activity because, you know, bleeding can happen 2 to 4 or even 6 weeks after one of these procedures. And the complications are not trivial. You know, besides the bleeding, there can be scar tissue. The bladder neck often develops restriction or a contracture, you know, in 10+% of patients. But over 60% of these patients will never ejaculate again, and 10% will lose their erectile function. There is also a measurable, you know, number of men who have incontinence after this procedure or these procedures. And patients seem to know this. Again, they don't ask us to do these procedures, unless they're desperate. That's my experience anyway. As for the heat therapies, like I said, these were popular. We were very involved in some of these, mostly microwaves. And, the advantages in office procedures, no general anesthesia risks, that sort of thing. Essentially no bleeding for the most part. But the disadvantage is a half an hour of quite a bit of discomfort. Catheters that may have to stay in for weeks because heat causes swelling, causes obstruction. So this recovery period of 6 weeks was pretty common. It's not as effective. These aren't as effective as TURP, and they have a high retreatment rate. And there are some measurable sexual dysfunction that follows. What's noticeable, or what's important to know, is conductive heat. So when a hot source of energy is placed here, it will gradually deteriorate as it moves through the prostate because of its conductive nature. And the newer therapy is convective, so we'll talk about that. So we have 7 million men on drugs, and up to 70% aren't compliant, and they don't want TURPs. And by the time they elect something more definitive, their bladders can look like this, seriously trabeculated and no longer as functional as they once were. I believe, many urologists believe, that we need to address obstruction more definitively earlier in the disease process, in a safer, easier, and better experience for the patients so that they actually might choose this therapy. So these are the newer therapies. We'll talk specifically about these. There are some investigational things, some of which I'm involved in, some injections into the prostate that kill cells, interesting. Some mechanical devices, sort of, one's sort of a spiral stent, another is sort of a tri-lobed, if you will, metal device that sort of opens the prostate upon removal, interesting. There's this thing called aquablation, which is a TUR of the prostate done by water. So it literally is a water pick evacuation of the prostate. It's all robotically guided. We're going to be starting to do these, I think, late this summer. And then there's this thing. So radiologists will, put a catheter anywhere. Here's, I think, some of the problems with PAE. Well, one thing is, if you've got a patient who has horrific prostate bleeding, this can save his life. So that's one thing. That's been around a while. But in 2008, people were starting to talk about it for BPH LUTs. There's only one randomized trial against TURP, 2014. TURP outperformed PAE significantly. It's described in the literature as technically difficult, even among these experts. There is a risk of unintended in-field embolization leading to things as scary as bladder and rectal necrosis. And yet, at least one Salt Lake City radiology department is advertising this online. So I would just caution you because there are no good studies. So we're going to talk about these two, and they're in chronological order of approval. This is the prostatic urethral lift. This procedure is performed through a scope under direct vision, and what we do in this procedure is we compress one of the lobes of the prostate through a tiny little needle. An implant is deployed, and then the suture, and you'll see this on the next slide, the suture compresses the lobe because outside the prostate is pretty fixed and rigid. Inside the prostate is very compressible. And so by doing this in numerous locations, we get an open channel. This has been demonstrated to be well tolerated under local anesthesia in a lot less than a half an hour and much better tolerated than the microwaves. This is the actual delivery device. This is the implant itself, a metal end, nitinol, nickel titanium, a small piece. This is on the urethral side, and this is just like an Ethibond suture. This was introduced in 2005, and then through FDA trials was cleared in 2013. Unlike every other minimally invasive therapy, we get a visual impact, which is very gratifying to a proceduralist, So we see what we accomplished. We're also very comfortable with where we place these implants. They're far away from the blood vessels called the dorsal venous complex, the nerves and blood vessels down here, which is where the erections happen. So it's a very safe delivery. These are the milestones that have been met in a randomized pivotal trial called the LIFT trial. All primary and secondary endpoints were met, and these show you some things that may not make a lot of sense to you, but this is a good improvement in the symptom index, a good improvement in the flow rate, but specifically no ejaculatory or erectile dysfunction. And by the way, jump down to this with me, now about 35,000 cases worldwide, and no one's ever reported erectile dysfunction or ejaculatory dysfunction. The data for the 5-year study, which is now over, was presented at the AUA in Boston. There's also a trial which was comparing this procedure to TURP, kind of a bold move, and in fact, in a number of ways, it performed very favorably. So CMS adopted this procedure and interestingly assigned it a first ever, one and only BPH procedural code with a 0-day global, primarily because there's not a lot happening in those first 90 days. We're waiting for AUA guidelines on BPH. They'll probably be a year or two yet, but the European Association last year published their guidelines, gave this based on these 20 peer-reviewed papers, gave it Oxford 1A level of evidence, which is the same evidence they gave TURP. This is the durability slide, basically flat lines in symptoms, in quality of life, and in flow. And if, as according to Rareborn's presentation, symptom relief achieved rapidly within 2 weeks, and at 1 month is very similar to what we can see in 5 years. Of course, there's exceptions. 13.6 patients were retreated in the 5-year period. Some had more of these, some had TURs. But if you compare that to the TUR retreatment rate, it's not a whole lot different. Yet the cost, if you will, the cost for the patient, the experience is much different. If you look at this comparative chart on the bottom, some of these other procedures have frankly just failed in terms of early retreatments. Payers are starting to pay attention to this kind of thing. So in this slide, the green line across is the PUL. This is a TUR procedure, a little more expensive. These are all drugs. Even if we're just using generic tamsulosin, the crossover occurs at 4 years in terms of expense to the system. So then let's wrap up with this other procedure. So this water vapor procedure called Resume, basically radiofrequency energy is utilized to heat water into vapor. The vapor is then transmitted into the prostate. As it becomes water again, it releases a ton of energy. It does so in a convective way, which is a much more precise type of delivery. And I think that's why it's going to work better than the conductive methods. This is kind of the system, radiofrequency generator, water, and delivery device. Pivotal trial looked an awful lot like the other trial. These were done under local. They did require a little bit more than the other procedure. A bunch of these patients required catheters, almost all of them. 7% had ejaculatory dysfunction, no erectile dysfunction, and good results, you know. And this is now published at 2 years in our journal last month. The impact on the patient takes a little while because, again, it's heat. Heat causes swelling. That's why these catheters are in for a while. And then gradually that dissipates. So the recovery is a little longer. It was cleared in 2015, and the AMA, on the advice of the AUA, assigned this the CPT code that is the same code as for the tuna procedure, which is radiofrequency delivered directly into the prostate. So this is a comparative slide. It's not based on, well, it's based on studies, and it's based on my experience with both procedures. Not many people in this country can even have this conversation because not many have done both. In terms of data, we have 2-year data with the Resume, 5-year data with the UroLift, and they both look pretty promising. And the convective heating will outperform conductive heating. Also, no substantial sexual side effects for either procedure. And in terms of clinical things, well, there's similar indications. The thing about this Resume procedure is you can treat the middle lobe that is occasionally present that we can't really treat with the other procedure. They're done in office, and Resume is super easy for a physician and a little harder for the patient. It's more uncomfortable. The immediate visual impact sort of sets the UroLift aside. There are no visible changes at the time of this procedure, and then we follow them, and sometimes there's visual change, and sometimes there's not down the road. Virtually all these patients require a Foley, and in the clinical trials, the 3rd trial that we did, it was down to about 20% of patients who required one following the UroLift. And then, you know, again, Resume patients recover more slowly with some irritative voiding symptoms. In terms of the economics, you know, if a urologist is interested in doing one or the other, the startup costs are about 1/10 for the UroLift versus the Resume. I think this applies to urologists and primary care. Our patients who say they're fine, well, they're guys. They don't want anything else. You know, they're getting up only 2 times a night. They were 4 times a night. They're pretty happy, and they don't want to scope or anything. So they say they're fine. We see this year after year. But they may need our help to realize they're not as fine as they could be, and we use these symptom score sheets very, very effectively to teach them and show them that maybe we can have some impact. I think watchful waiting is sort of a danger zone if the patient's not being followed, and of course a guy isn't going to be followed unless he has a problem. So, I think we see a lot of these guys in the ER with big residuals requiring catheters. Medications are what they are. They're really not that powerful respective to the procedures. They have lots of side effects, and men in general, I find that they just would rather not take a pill for the rest of their life. Minimally invasive options, and we're seeing some of them in the talk and others that are upcoming, they've improved. They're still evolving, and men, generally men prefer these over trips to the operating room. I think TURP, that's been called the gold standard for literally almost 80 years, I think it's being challenged across the country in clinical trials, and I think we can do better for our patients with some of the alternative therapies. And feel free to write our emails and our cell phones down. We're all going to provide these to you. These are my Studley boys who I played golf with this weekend, so thank you very much. And again, questions at the end. Thanks.
Just red buttons. Plus. I'm Scott Hopkins. I've talked to many of you, don't know by face everybody. And I'm going to talk about PSA, which I'm sure you've seen a lot about in the last few years. So no disclosures. I don't work for any of the companies, any drug companies, anything like that. Just some basic data on prostate cancer in the United States. Over 160,000 new cases in 2016, 2000 per year. These are 2017 estimates. About 27,000 deaths a year. So it's not an insignificant problem. Sometimes hear on the news that we don't need to treat prostate cancer. It's not a problem. We see these patients dying. The medical oncologists and radiation oncologists see them dying, and it's a miserable, slow death. It's the third leading cause of cancer death in men after lung and colorectal. There are times when prostate cancer from year to year will overtake colorectal. They're pretty close, and they go back and forth. 1 in 7 men will be diagnosed with prostate cancer, and a little bit fewer than 1 in 30 will die of prostate cancer. The average age is 66. We usually see it from the mid to late 50s. Although I know that I've had a patient in their late 30s. I know Steve's had at least one in his late 30s. It's not unheard of, but it's very rare to see it in men under the age of 40. This all started with the U.S. Preventive Services Task Force. First in 2008, when they recommended no screening for men older than the age of 75. I think most urologists in the AUA are fine with that. In 2012, they came out with a much more negative evaluation of PSA. They gave it a D grade and said that we should not use PSA at all, that PSA is a worthless test. And then in 2017, there is a draft statement saying that this should be a shared decision-making between the ages of 55 and 70, and no screening greater than 70, giving this a C grade overall, relatively comparable to mammogram. So not as good as colonoscopy for colorectal cancer. So the rationale, they used 2 studies and gave them equal weighting. One is the PLCO, prostate, lung, colon, and ovarian cancer. That trial showed no benefit between the screen group and the control group at 13 years. There's a large multinational European study which did show some improvement, but they looked at the total number. So 1 life saved per 1,000 screened and 1 life saved per 37 cancers detected. And this is at 11 years, so slightly shorter. One thing you need to understand with prostate cancer is when we look at data, we need to look at 10 to 20-year data, not 0 to 5. We look at testicular cancer, at 2 years, you know what happens. With prostate cancer, it's more in the 10 to 20-year range that we really know what happens. They also looked at the harm of treatment. We look at biopsy, a not insignificant risk of infection. Somewhere between 3 and 5% will see urinary tract infections. And there is a measurable risk of sepsis from a transrectal ultrasound and biopsy. I have to admit a patient every 3 to 4 years to the hospital. That's probably relatively similar to what my patients or my partners see. And then when we overdiagnose cancer that is not going to affect a man during his lifetime, and the side effects of treatment with quality of life loss that goes along with that. I won't go into that at this point in time, but there are clearly side effects to treatment, whether that's radiation, hormonal therapy, surgery. There are known side effects. There are some pretty significant problems with the USPSTF reports. Number one, this is, and we love our primary care physicians, this is 12 primary care physicians. There are no physicians who take care of prostate cancer patients on a regular basis. There was not a urologist, a medical oncologist, or a radiation oncologist on this. The PLCO trial has a very high contamination rate. Everyone would agree it's at least 52%. As I reviewed a number of papers talking about it, up to 90% of the men who were in the control group were screened with PSA. And so they did not separate those men out. And so that you can, if 90% of the control group who were not screened were actually screened, it changes your number significantly. The benefits of treatment accrue with time. The longer you are out from diagnosis and treatment, the better the outcomes are. At 20 years, 2 to 5 men treated to save 1 life, which is very similar to breast cancer. Women have been much better advocates for breast cancer than men have been for prostate cancer. Stage migration and cost. Up to 6,000 additional deaths per year is one estimate with the complete cessation of prostate or of PSA screening. I don't have data, but we have started to see more advanced prostate cancer just in the 5 years since the 2012 USPSTF. Well, since I'm halfway through, we're getting better at risk stratification. There are numerous studies showing that we have decreased the risk of dying from prostate cancer during the PSA era. The chair of the USPSTF said we cannot distinguish cancer that will never make a difference in a man's lifetime from cancers that will make a difference with PSA, and that's absolutely true, but biopsy can make a difference. From 2012, there's been a 64% decrease in digital rectal exam screening. Those recommendations did not talk about DRE at all. 39% decrease in PSA screening and a 30% decrease in biopsy. I think in our practice, it's significantly higher than that. We've probably seen a 50+% decrease in biopsy. We have also seen more advanced prostate cancer, and these are documented, and more prostate cancer-specific deaths and more metastatic disease. High-grade prostate cancer, which is Gleason score 7, 8, 9, and 10, has increased by 5 to 6% in those 5 years. Where do we go from here? New draft statement from the Preventive Services Task Force. They recommend that patients should have a decision in this. We should talk about the risk and benefits of screening. Men from 55 to 69, they give it a C grade, greater than 70, that they shouldn't be screened. This is just published as a draft at this point in time. We don't know when they're going to make a final decision, but I imagine it will be at least a year. This is in line with the American Urologic Association's best practice guidelines, which were published last in 2013, after the 2012 statement came out. The AUA best practice guidelines recommend against screening in men under the age of 40. Men aged 40 to 54, routine screening is not recommended, but not actively discouraged. There's great data to show that a single PSA before the age of 50 can risk stratify. So if your PSA is less than 1 before 50, you probably don't need to start screening until 50 to 55. If it's greater than 1.5, then you might want to start screening earlier. Shared decision making in that bulky group of 55 to 70, routine screening interval at 2 years, and recommend no screening greater than 70, but don't actively discourage it because men are living longer if life expectancy is greater than 10 to 15 years. These are relatively similar to the American Cancer Society's recommendations. No firm recommendation, but if there's a greater than 10-year life expectancy, you can consider starting screening at the age of 50 for average risk, age 45 for men that are African American, or if they have a single first-degree relative, at the age of 40 with men who have more than one first-degree relative. If the PSA is less than 2.5, test every other year. If greater than 2.5, test yearly. National Cancer Coalition guidelines are a little bit more aggressive. They recommend a baseline rectal exam and history, a single test at the age of between 45 and 50. If the PSA is less than 1, basically you can wait until 50 to 55 to screen. If it's greater than 1, then you should screen those men every 1 to 2 years. Between the ages of 50 and 70, if they have a normal rectal exam, screening every 1 to 2 years. There's a lot of disagreement about biopsy threshold. Stop PSA at 75, except in very select patients. Future and past, digital rectal exam is still important. Up to 20% of all prostate cancers are discovered in men with a normal PSA and a positive rectal exam. So we can't discount rectal exam. We can use percent-free PSA. I know some of you do because I see some of your patients. It can help. There's not universal agreement about it, but it's a good test. We're better at biopsying now, especially in men who've already had a biopsy using MRI. There are some blood tests, which I have not used a lot, and Peter Fisher has a little bit more. There are some genomic tests, and I'm going to, because I'm running out of time, quickly talk about one that I think is going to make a significant difference. Select MDX is after we do an aggressive prostate exam and massage, we then get a urine sample. They mark this for 2 mRNA messengers. It's combined with a bunch of other historical things to give a score. This is from the main trial that has not been published yet, but is online. You get a score from -6 to +4, and this is no prostate cancer. So as the score goes higher, your risk of prostate cancer goes down. This is the risk of low-grade prostate cancer, Gleason score 6 or lower, and this red line is the risk of high-grade prostate cancer. So as this score goes up, you're going to have less risk of no prostate cancer and more risk of high-grade prostate cancer. I am using it right now in men who have already been biopsied, and I'm still worried about their PSA. I'm just starting to use it in many men to decide whether they should have a first biopsy, and I think it has potential use in the primary care setting to improve the referrals that you're giving to us. So that is, that's PSA in 10 minutes, which is kind of hard. So I'm going to turn the time over to Peter Fisher.
Well, good evening, everybody. I'm really happy and I feel lucky to be here to talk about prostate cancer. What I've chosen, let's see if I do this right. There we go. What I've chosen to take tonight, I don't have anything to disclose, but I wanted to go over in a little bit of detail a new guideline that we have in our specialty. AUA stands for the American Urologic Association, and as an association group, we are given guidelines on a number of disease states, anything from hematuria to testicular cancer to stone management in the ureter or in the kidney, and prostate cancer, whether it's localized or metastatic. And new to 2017, the recommendations or the guidelines from our national organization for localized prostate cancer has changed. And I want to go over this in some detail with you as primary care providers because I think there are 2 things that are really important for us as we care for patients and as we work together. One is that you know when you send patients to our Summit Urology group that they are getting what we feel is the best quality care that we can give them, that is national information that's been heavily scrutinized, that we are trying to keep each other abreast of the most current information that is there. And two, and probably more importantly, that information is getting to your patients. Because our job as surgeons is, I don't think, to dictate what care exactly a patient should receive, but to have a shared decision-making model that we can advise and guide and come to these solutions together. I think that's proper patient care. So these AUA guidelines, I've referenced it here. They're available online through the AUA's website. And of course, there are a multitude of other guidelines. If you ever wanted to peruse it, it's a healthy data bank. I'm very proud to be part of a specialty that puts its first priority in shared decision-making between physicians and patients. Rest assured, when we have a patient that is diagnosed with prostate cancer, that we have diagnosed with prostate cancer, maybe from a palpable lesion or maybe from an elevated PSA, those patients have a sit-down cancer talk. And maybe many of you already know this, and this is overly redundant, but I think cancer talks are a very important part of our specialty as surgical specialists. Most of us in our group will take an extra amount of time with these patients, put these appointments at the end of the day or over lunch hour so that they can invite family members. We can sit down and take whatever time is needed to go over their biopsy results and go over the treatment options as they exist and come to a shared decision-making tree together. I think that's a really important part of our practice. As many of you observe other physicians, sometimes it's a little easier in medicine to just tell a patient what their problem is and what surgery they should have done, or what procedure they should have done, or what medicine they should have. It's a lot more difficult to be a surgical educator or a medical educator for patients, and something that it is crucial to maintain in our specialty as well as yours. Risk stratification. For 2017, new to the stratification of localized prostate cancer is this very low and low risk modality. I can get into the details later if you have questions about what qualifies a patient for very low versus low risk. As a specialist, we all know that, so I think that we're generally the ones that are going to counsel patients in this regard. But suffice it to say, our guidelines are now leaning heavily towards a recommendation to active surveillance for very low-risk prostate cancer and suggesting active surveillance for low-risk prostate cancer. There are some patients in low-risk categories that we may feel have a higher risk. Maybe they are very young. Maybe they have a family member with high-risk disease even though they've been diagnosed at low risk. Maybe they have a suspicious lesion on MRI or otherwise that prompt them towards definitive therapy. But our guidelines are moving this category of patients towards active surveillance. Active surveillance, I think it's important to note, in our guidelines is spelled out, and you will see this come back as your patients have their care through us, that they will get a confirmatory or a pretty soon biopsy within a couple of years of their initial biopsy if they're on active surveillance. They may get an MRI exam, and they may get other genomic tests. Those are more elective as according to the guidelines. But active surveillance is playing a much more pivotal role because you know, just like we know, prostate cancer has an overtreatment problem. It is the overtreatment problem of prostate cancer that gave PSA a D grade from the U.S. Preventive Task Force. And like it or not, it's made us as physicians start to think much more critically about the long-term needs of patients. Like Dr. Hopkins said, this is not a 5-year disease, probably not a 10-year disease, but a 20-year disease. And we'll get into that in a little bit more. Many of you know this New England Journal published last fall. It received headlines. Is there a laser pointer on this? It received headlines because of this graph right here. This is 10-year prostate cancer survival for men with low-risk disease randomized to active surveillance, or what they called active monitoring, surgery, or radiation. And over 10 years, there was no statistical difference in cancer-specific survival. That's what grabs headlines. Well, if that's the case, to the layperson, why on earth would we ever treat anyone for prostate cancer with its associated risks? Why would we ever screen men for prostate cancer if there is no difference? As we've dissected this information and learned more about it, I think what lies, as usually studies do, there's much more behind the scenes. This graph that's also in the paper, I think, is much more telling. What you see on this particular graph is men who have radiation and surgery in these groups. They are assigned to their groups and continue out through time. But in the active monitoring group, these are men who fell away from active monitoring and received treatment. 50% by the end of their 10 years had transferred from an active monitoring state to a treatment phase. This is what we see in our practices. When we have men on active surveillance, and what we fear with active surveillance are the guys who get a diagnosis and then disappear. Because as they go through regular PSA monitoring, repeat biopsies, regular digital rectal exams, their risk can change over time. 17 men in this study died of prostate cancer. The reason that there is no difference is because, according to their stratification, active monitoring men who died, there were 8 of them. Treatment men, there were 9 of them. The highlighted red are men who were initially diagnosed with Gleason 6 disease or low-risk prostate cancer. What I think is very telling, this is not in the paper. This came out of the group scrutinizing it to, look back at those who actually died. What were their characteristics? The men who died, even though they were assigned active monitoring, prostatectomy, or radiation, that was an intent to treat with the study, if you're familiar with an intent to treat analysis. These men, most of them, started in an active monitoring phase. Though they were assigned, that's an intent to treat assignment. And all but 4 of them, the men who died, started in an active monitoring phase. I think that's very telling. And the other issue with this particular paper is about 10 years. I should probably have some of my partners who have a lot better verbiage and seeing men happen through 10 years of prostate cancer monitoring, how their disease progresses and what treatments they endure. I've been in practice now 11 years, and there are many men that I have on active surveillance or who've had prostate cancer who are alive 10 years after treatment. But aggressive disease, though survivable at 10 years, comes at a cost that can be severe if their disease has been delayed, if their treatment has been delayed and their disease goes from surgery to adjuvant radiation to erectile dysfunction to urinary incontinence to hormone therapy, adjuvant hormone therapy or chemotherapy and so forth. So men survive, but at I think, substantially greater cost. According to guidelines now, an intermediate risk disease, we consider screening these men with CAT scan, MRI, and bone scan, depending on their risk, some of their more detailed risk stratification, and to consider giving androgen deprivation therapy with radiation. Still, intermediate disease recommended guidelines are generally towards therapy, prostate cancer surgery, or radiation. But active surveillance is an option for men of a lower deemed risk in that intermediate category. Men with high-risk disease should have CT scan, should have bone scan, should have androgen deprivation therapy for a prolonged amount of time. And I think this is interesting to consider genetic counseling. A new kind of wrinkle in our recommendation that you should be aware of. Genetics, particularly in first-degree male relatives, dramatically increases one's risk of prostate cancer, and particularly high-risk cancers. And genetic counseling, I think we're seeing more common across all cancer modalities. As a personal aside, while we're on this topic, my father, now 80 years old, at 72 years of age, I diagnosed my dad with prostate cancer. He had low-grade prostate cancer at the time, Gleason 6 disease and a palpable nodule, which would actually make him intermediate risk. But he was 2 years out from a heart transplant. Well, 3 years almost. He had a heart transplant at age 69. And I told my dad when he was diagnosed with prostate cancer, your heart disease is going to kill you long before your prostate disease will. You should enjoy whatever sexual function you have, and I don't want to hear about it. But let's observe this disease. As we had him on active surveillance with immunosuppressive drugs for his heart transplant, his PSA went from 6 to 9 to 12 in progressive 3-month intervals. And we rebiopsied my dad. And he had high-volume Gleason 7 disease with a couple of cores of Gleason 4 plus 3, so a little, still Gleason 7, but more aggressive. Now, it would be interesting to poll my colleagues, or even you physicians, of a 75-year-old post-heart transplant with disease in the prostate that has taken an aggressive turn. It is now intermediate to intermediate high-risk disease. How long does he have to live? His PSA doubling time, as best as we can tell, is certainly less than 12 months. And I had to have a great, frank discussion with my dad about what his life goals were. How long do you want to live? How long do you think you're going to live? Because it would be a terrible irony for my dad to die of prostate cancer, right? After the careful shared decision-making, he had treatment with radiation, and his PSA has been very low, and that's the only treatment that he needed was brachytherapy. And 5 years later, personally, on a personal note, I'm elated with my dad's therapy. And at the prostate cancer run, we have our whole family involved in my dad's journey, and it's been a great thing for all of us. I wanted to say just a couple of words that are in guidelines about emerging therapies. Whole gland cryotherapy, which is actually not so emerging anymore, it's been around for some time. And HIFU and focal therapy. According to our guidelines, you need to understand whole gland cryotherapy is best suited to men with low-risk disease. It can be offered for intermediate risk disease. It should not be offered for high-risk disease. It comes with substantial side effects that patients should be aware of, such as urethral sloughing and erectile dysfunction. HIFU, which is high-intensity focused ultrasound ablation, it is arguably the least invasive prostate cancer, well, I should say prostate ablative treatment. It is FDA approved for prostate ablation, but not prostate cancer treatment. And our guidelines recommend that focal therapy and HIFU be confined to an ongoing clinical trial for patients. I wanted to show you this. This is the prostate cancer, the Zero Prostate Cancer Run. This is me, and this is our team. This is my dad here in the middle, and this is my siblings and their families that we came to celebrate with my dad. I don't know what my dad's going to die from at this point. He's 11 years after heart transplant and doing exquisitely well, and I just worry when we go skiing together that he's going to fall and break a hip or something because he barely gets off the lift while he's wheezing. Fantastic. I guess we'll take questions after the fact. I may be a little early, but that's okay. Thank you.
Good job. Hello, my name's Peter Caputo. I am one of Summit Urology's newest physicians, and I was tasked with presenting on common urologic referrals. However, after the BPH talk, the PSA screening talk, the prostate cancer talk, hypogonadism talk, there's not much common urology left, so I will be presenting on common referrals as well as some uncommon referrals. I have nothing to disclose. We will be talking about hematuria, Peyronie's disease, and urological emergencies. We'll get started with hematuria. The rates of microscopic hematuria in health screenings range from about 2% to 31%. There are higher rates in men over age 60 and also in men or women who are past or current smokers. The most common etiologies of hematuria are infection, urinary lithiasis, BPH. However, the thing that we worry about, or at least that I worry about as a urologist, are the things that are really dangerous to patients. Those things are urinary tract or urologic malignancies. So although they are not very common, they are significant. So in patients with microscopic hematuria, about 4% of those go on to be diagnosed with a urologic malignancy. There is a big jump when you get into patients with gross hematuria, particularly those patients who are men aged 60 to 69. You see the rates there, those men have about a 29% chance of having a urologic malignancy. Most of those men are diagnosed with a bladder cancer, okay? Men aged 50 to 59 are about 20%. Women, the increase is not quite as dramatic, but still significant. 21% of women aged 60 to 69 will have, with gross hematuria will have a urologic malignancy, and about 9% of women 50 to 59, okay? So how do we diagnose hematuria? It is important to note that dipstick urinalysis is only a screening method. Anyone with heme on a dipstick should get confirmed with a microscopic analysis. Once microscopic analysis confirms blood, we need to see at least 3 blood cells per high-powered field. That's the American Urologic Association's guideline on what the cutoff should be so we're not over or under-diagnosing, okay? So what do we do once we do have a diagnosis of hematuria? We want to find out or rule out any benign etiology. Those benign etiologies are found by doing a thorough history and physical exam plus laboratory evaluation. And we want to identify any infection, stones, menstruation, vigorous exercise, medical renal disease, viral illnesses, trauma, or any recent urologic procedures. So in patients who we do identify a benign cause, those can be treated, and then urinalysis can be repeated a few weeks later to see if the hematuria resolves. In those patients who we don't find a benign cause, that would warrant a urologic evaluation. A urologic evaluation would consist of estimation of renal function with glomerular filtration rate, a cystoscopy. Cystoscopy should be offered to all men who are greater than all patients who are greater than age 35. And then it could be offered to those people who are younger than 35 with high risk factors like exposure to carcinogens, heavy smoking history, gross hematuria would be considered a high risk factor. Then we have, the next step would be radiologic imaging. Renal ultrasound is the minimum, and it is actually very good for patients with asymptomatic microscopic hematuria. However, cross-sectional CT or MR urography would be, in my opinion, warranted in patients with high risk or gross hematuria to find that just evaluates the ureters a little bit better than a renal ultrasound would. The next point is routine urine cytology isn't recommended for all patients. So patients with asymptomatic microscopic hematuria shouldn't just get straight off the bat cytology. Cytology I reserve for patients who have persistent microscopic hematuria even after a urologic evaluation has been negative, or in patients with gross hematuria who have been previously negative urologic workup, or those with high risk factors. So it's important to know what are all these evaluations looking for? What is the renal ultrasound looking for? What is the cytology looking for? What is the cystoscopy looking for? So basically, any point along the urinary tract is a spot for a malignancy to develop. So the renal ultrasound evaluates the kidney and the kidney parenchyma where a renal cell carcinoma or another parenchymal tumor would form. The CT urography or MR urography would evaluate the same thing, the parenchyma, but it would also, in addition, add the ureters to make sure there's no ureteric mass. The cystoscopy would obviously evaluate the urethra and the bladder for any urothelial lesions like a bladder cancer or urethral cancer. And the cytology is kind of reserved for patients without any radiologic mass or without any cystoscopic mass. Those things are like carcinoma in situ of the urothelium. So the cytology is really, we're using that to try to identify a flat urothelial lesion that's not visible on radiology or cystoscopy. So the next topic I'm going to talk about is Peyronie's disease. The prevalence is 8.9% in the United States, and some might ask, well, what's the big deal? Why do I care if a man's got a curved penis? It's not prostate cancer. It's not some other devastating diagnosis. However, studies show that over 80% of men indicate that they have some type of emotional distress associated with their Peyronie's. Almost half of these men indicate that they have experienced some type of depressive symptoms, and over half state that they have had relationship difficulties and stressed relationships because of their Peyronie's disease. So it's an important quality of life factor that should be addressed if we can identify it in our patients. So what is the etiology of Peyronie's? It is caused by an inflammatory process of the tunica albuginea, which is the capsular elastic capsule of the corpus cavernosum, which basically contains an erection. And when the when these micro traumas happen to the capsule of the albuginea, then we get type 1 collagen conversion to type 3 collagen. We lose elastin, and that prevents that side of the tunica albuginea from expanding like the other side, so it creates a buckling and a curve. So the natural history of this is with regards to pain and curvature. This is from a study that looked at men from initial diagnosis without any treatment, and then it looked at these pain and curvature endpoints at 12 months. So the pain routinely improves in all patients. However, it only completely goes away in 89% of patients at 1 year. The results with curvature aren't quite as good. Only 12% of patients improve with regards to curvature, 40% remain stable, and 48% worsen over time. So evaluation, typically the men coming in and complaining of this is a man over 50, and they will complain of recent or acute onset penile pain associated with penile curvature. A less typical patient would be a younger man that complains of the same thing. The only difference is younger men typically always remember an incident. They say, an event during intercourse that happened, and they felt a trauma or something happened, and then they more likely have a palpable mass of the penis. Okay, so the evaluation, we should evaluate their symptoms and also have a thorough examination to evaluate for any palpable plaque or even mass of the penis. The treatment, the two things we focus on is the pain and the curvature. Mostly the pain gets better, but if patients are having difficulty with pain, NSAIDs are the mainstay for therapy. Patients that have refractory pain or pain that is particularly cumbersome, extracorporeal shockwave therapy can help with pain, but it does not help with curvature. When it comes to the treatment of the penile curvature, it is important to note that invasive treatment should only be recommended to those men with stable plaques. So that means a curvature that has not been getting worse for the last 3 months and pain that is at least stable or not getting worse for the past 3 months. If the plaque is still developing, you should hold off to start thinking about invasive treatment. So the first treatment choice for people or men who have adequate erections for intercourse with or without medications is, and with curvature of only 30 degrees to 90 degrees, the first treatment choice would be intralesional collagenase injections, which kind of breaks up the collagen scar tissue of the albuginea and allows that to expand a little bit better. For patients with more severe curvature or who have failed that treatment, surgical options are available. So we'll first talk a little bit about the intralesional collagenase injection. It consists of 2 treatments over the course of 2 to 3 days, and then 6 weeks of modeling, penile modeling, to help disrupt that scar. You can have about 4 to 6 of these treatments over the next ensuing few weeks to see if you can straighten the penis out. Once we get on to different surgical treatments, plication would be one option for men with non-severe curvature. And the plication is just putting you can see the scar here causing the curvature. Plication would just be putting some stitches contralateral in the albuginea to actually create an iatrogenic scar on the other side so the penis is actually straight. A graft is where we actually excise the scar and replace it with either a cadaveric graft or a bovine pericardium graft to reconstruct the tunica albuginea. And then last, prosthesis is an option, a good option for men who no longer have erectile function but want it and they have severe curvature. The penile prosthesis is surgery where we implant 2 chambers into the corpus cavernosum with a pump dependent in the scrotum and a reservoir in either the subcutaneous tissue of the abdomen or the retropubic space. Therapies that should not be offered that have shown over and over again to not be any better than doing nothing are vitamin E, omega-3 fatty acids, vitamin E plus L-carnitine, tamoxifen, procarbazine, electromotive verapamil, and radiotherapy. So this is the part of the talk where I talk about urologic emergencies. I hope everyone's done eating. That exclamation point is there for a reason. So this is kind of like the rapid fire. So the first would be testicular torsion. The most common presentation of a testicular torsion is a young man with acute onset severe testicular or scrotal pain associated with redness and swelling. Some of the ways to distinguish this between epididymal orchitis is the typical Prenz sign, that is relieving of pain with elevation of the testicle, which would point you in an epididymal orchitis direction, or loss or presence of the cremasteric reflex. So if the cremasteric reflex is lost, that would be more indicative of a testicular torsion. So if you ever have any questions, it's just these people need to get straight to the emergency room or a urologist so they can be evaluated in a timely fashion so we don't end up with a ischemic and dead testicle over here seen on scrotal exploration. Next thing would be paraphimosis. This needs to be distinguished between phimosis. Phimosis is a narrowing of the foreskin which does not allow retraction of the foreskin. Paraphimosis is phimosis that actually makes it over the glans penis and stays in a contracted and retracted position over the glans, inhibiting venous outflow, which can get bad enough that the swelling can get bad enough that it inhibits arterial inflow and can ensue with, like, penile necrosis can ensue if these aren't treated soon enough. So the typical feature is the almond blister sign, which is the swelling of the foreskin but behind the glans penis. And believe it or not, even I sometimes can get fooled by these, and it looks like a balanitis type picture, and you say, well, this is balanitis, we'll give them antibiotics. But you really have to look for that constricting band, and you got to ask the patients, have you been circumcised? Because if you don't ask that, you're not going to know. So the way we deal with these is you can either put pressure, manual pressure over the edema, and then you can retract the foreskin, or we do a quick dorsal slit, which is just a surgical incision of the foreskin to allow it to open. Next thing is priapism. This is a little statue of Priapus, who is the ancient Greek god of fertility. So when it comes to diagnosis of priapism, it's kind of a no-brainer. No one really needs to know. So someone will come in and tell you they've had an erection for the last 72 hours or something. So the mainstay of treatment, however, is aspiration of blood using a large bore needle that goes into the corpus cavernosum. The blood is aspirated. Then if that doesn't work, you can irrigate with saline to help break up any of the clots that have formed in the corpora. If that doesn't work, phenylephrine injection to be injected directly into the corpus cavernosum causes arterial constriction, reducing the blood flow. It should be noted that if we do use phenylephrine, they should, particularly in older men with cardiovascular disease, we should have very stringent monitoring of their cardiovascular parameters, heart rate, blood pressure, to make sure that none of this gets systemic. Last resort is surgical therapy with shunting from the corpora to the spongeous tissue to allow a shunt to form so the blood can escape back to the venous return. Next is a penile fracture. This is the typical eggplant sign that you hear about. These people usually come in to your clinic complaining. The typical story is they were having aggressive intercourse, the penis was withdrawn, it was attempted to be reinserted and missed, and they immediately hear a snap. A snap is an important finding on the physical exam and history. The snap is routinely always followed by severe pain, loss of erection, and penile swelling. So that's just an actual eggplant. The treatment for that is immediate urologic penile exploration to evaluate for any defect in the corpora, which is debrided of any non-viable tissue. The albuginia is repaired. One note that I will tell you is that if these patients cannot urinate or have blood at the meatus or blood in the urine, they should always be evaluated for a concurrent urethral injury, because if that's missed, it could cause some severe problems with urethral stricture in the future. And the last thing I will talk about is Fournier's gangrene. Fournier's gangrene is a polymicrobial necrotizing infection of the groin, the scrotum, the perianal area, and it can progress extremely quickly. The physical exam, normally you will see a severe infection. There can be crepitus. Crepitus should always tip you off to actual Fournier's gangrene. If you see crepitus or necrotic or black skin, just immediately start broad empiric antibiotic coverage to cover a polymicrobial infection, gram negatives, gram positives. And the next thing to do would be immediate surgical debridement. If you see in this patient, you have to remove every piece of non-viable tissue and deal with the reconstruction consequences at a later time, because this surgery can be life-saving. That wraps up the talk. That's my contact information. If you have any questions, we'll save them till the end.
Hey, thank you everyone for being here tonight. I'm Lane Childs, and I'm really, I have nothing to disclose either. We've seen a lot of bad ball pictures, so I'm going to show you some good ball pictures for a second. I'm proud of these because I actually took these just a couple of months ago, and there's nothing like the original government issue for a problem that we all see. We might not every day have to deal with lots of difficulties with prostate cancer and the details of which road to go down, but I bet you get plagued with hypogonadism issues all the time in your office. There's lots of questions. Everybody's searching for the fountain of youth, And so I'm going to talk about some details. And frankly, I'm glad that I got assigned this. I wasn't at first, because I think a lot of these talks, any one of us could probably stand up and give you a talk on pretty much all of these topics, except maybe, at least I'm going to speak for myself now, this one, because I know a fair amount about it, I feel like, but the details is tough for me to really quote you chapter and verse on some of the literature on what's spoken. So I'm not going to read all the references and whatnot, but you know, there's all the stuff there, and if you're interested, you can find the stuff there. But I learned a lot doing this talk, so I'm going to try to pound through this, and then we can deal with those questions later. Basically, hypogonadism is really a pretty new term. And I should just mention, I said it first, you know, this is not your father's hypogonadism or low testosterone sort of speech, because things have really changed. So I'm going to kind of come back to that as I finish up. But basically, this endocrinopathy is really a combination of more than just symptoms and whining from your patients about getting older. It's not just a lab test result. It's a combination of everything. That's what makes a difference in trying to determine whether or not, you know, one treats this. And this MSAM, this multinational study on the aging male, has been already referenced by Dr. Gange, but it shows basically these numbers. You see these natural amounts of increasing testosterone decline just by sheer aging factors. And basically, the math works out to about a 1.6% decline per year, okay? So that's pretty significant, just by natural time and aging here. So basically, as good, you know, little studious doctors, we've all done endocrinology 101, and we kind of think, okay, which category is this? You know, there's that pituitary thing going on, and there's that hypothalamus thing going on, and what category do they fall into? And the reality is that as we go through all the stuff, a lot of our patients fall into category 3, which is none of the above. And basically, just to remind you again, primary testicular reasons for low testosterone. Your testicles got, you know, bad torsion, you know, like Peter just talked about. Or they got radiated, or that you have some genetic Klinefelter's thing, or, you know, all these kind of things. And then you get these vague things like these receptor gene mutations that, you know, happens, but it's not the obvious stuff that we figure out in our office visit. But that's one of the reasons for primary testicular pathology. And then same kind of thing can be going on in your noggin with your pituitary or your hypothalamus, and have a pituitary reason for hypogonadism. And, you know, Kalman syndrome, one of those board questions that we all kind of think back and remember about. And anyway, some of these kind of things, diabetes, all these chronic conditions can affect your brain and affect the low testosterone. And then when the people don't fall into any of those categories, there's kind of this last gizmo here, which is basically this adult onset with inadequate pituitary response. I mean, the brain is not kicking into gear, and you're just left with this low level, okay? And that's what a lot of these patients have got when you really get in and do the science here. So I think that as I got thinking about how to do this talk, I thought a brief little bit of history is worthwhile. And this goes back to one of my favorite books. If you've never read the book Charlatan, do it sometime when you really want a good smile, because Charlatan, this is a true story about Dr. John Brinkley, and doctor is in little marks because he was a manufactured, you know, he basically bought a diploma. It's totally bogus. He had no more medical training than, you know, about a 5th grader. And, but interestingly, he got pretty famous in the early 20th century, and what did he do? He did transplants. But, you know, and when you think of a transplant, it's a high-tech, sew the blood vessels together and all that. This guy basically sliced people's legs or abdomens open, and he'd gone to the research with his zoological buddies, figure out which are the toughest, nastiest, meanest animals? Goats. And he got a lot of goat testicles, and he implanted them in upwards of 16,000 people in the 20s, early 10s and 20s, in the 1900s. This is crazy that this happened. If you've never heard this is a great story. You should read it in this book. Okay, there was a lot of people who got a temporary buzz, felt stronger and all this, and anyway, interestingly, Dr. Brinkley always wore a goatee for his whole life. That's not coincidental. And anyway, this Morris Fishbein, if any of you have ever maybe remember that name, in JAMA, as recent as just a few years ago, there's a picture of a really old-looking bald guy where different study and research awards were given out, the Morris Fishbein Awards. Fishbein, years later, was the editor-in-chief of JAMA, for a big AMA dude, for a long time. So anyway, back when he was a youngster, he hounded this Brinkley guy and brought him down. And it's a great story. Why I mention all this stuff, because it's entertaining, but also because this bad science really stimulated a lot of interest in testosterone and basically hormone research. And so basically, right about that time period, it was actually 1937 that testosterone was isolated and synthesized. They really started learning a lot about it. It was given for all these, aches and pains and malaises. But interestingly, at that point, Charles Huggins and Hodges, these two determined the association of the hormone sensitivity of prostate cancer. And that information was in 1941. Years later, from some other refined research, actually Huggins was awarded in 1966 the Nobel Prize for Medicine. He shared it with another individual. So anyway, this is big-time stuff, and this is stuff that we use every day in terms of prostate cancer management. But the key reason all that's in there is because it led to this idea, and this is our father's thinking, shall we say, and that is that testosterone, if you lower your testosterone, it's a treatment for advanced prostate cancer. So if you have a lot of testosterone, that's got to be bad for the development or the promotion of prostate cancer, okay? And that's called this hormonal theory. And again, I'll have more to talk about that in a second. But we have to kind of keep that in the back of our head. So with that idea, some research comes along. There was a bunch of lizard studies that were done on, and I say castrated subjects. I don't know how a castrated lizard acts, but they have studies that show that there was a normalization of behaviors and all that in these animal studies. But still, for a long time, there's a very slow acceptance of testosterone treatments. And then finally along comes more options. And instead of men getting testosterone injections, there's medication that can just be put on your skin. How simple can it be? And so that really led to the explosion of the testosterone therapies. And over the next little while, boom, we have like over 20 different options available. And that increased usage leads to increased scrutiny, because here you have all of a sudden a ton of stuff getting done, a ton of insurance companies paying for things, and everybody's going, what jives? Do we have legitimate science to back this up? So that leads to two things that I think we should mention, and there's two specific articles that really stirred the pot. In 2013 and 2014, the vegan article and the Finkel articles came out, okay? And this vegan article basically was in JAMA, and this is the article that basically took 8,700 vets and compared their testosterone consumption, basically. Some had been treated, they'd had coronary angiograms and all that, and the bottom line is there was this report of a very high rate of adverse events, stroke, heart attack, death, and it was, these numbers. You see 25.5% versus 19% in the non-testosterone treated patients. And they said immediately, they drew a conclusion and said, aha, testosterone is killing people. And this went out in JAMA, a very reputable article and all that, and got a lot of press. And then people started dialing in and started going, okay, let's just look at this and start to see. And they realized that there were actually a lot of patients in the original cohort that were excluded for different reasons and weren't included in different reasons. And even best of all, my favorite, 10% of them were female, okay? So the data is, there's tons and tons of people who just said, this article is bogus, retract it. And so that's kind of where it sits. And yet it's out there, a lot of people saying testosterone and heart problems, boom, but because it was in JAMA. Now at the same time, or just shortly afterwards, this article came out in another less well-known journal here, but anyway, this individual did an insurance retrospective review. And in this basically, they took people who had received a testosterone prescription, and they compared their MI rates in the patients that received that as compared to what had been gone on in the year before, and came up again with these numbers. There was no control group. There was no control group in the number of patients that did or did not receive prescriptions. So again, just the basic science that we know of, really trying to understand the statistics of it, you can't even make any sort of evidence and data from that kind of information. And when people went in and dialed down the details and tried to calculate what actually was their MI rate utilizing an accepted, understood NIH heart attack calculator, apparently there's algorithms for that, and Ron can probably talk about that here in a while. When they actually did that, in this particular cohort, the heart attack rate in the reported people was actually less, or in what they expected was actually much less. So it further added to the confusion and what people think is the worthlessness of that particular article. So talking about other CV risks, the problem is both of those things really ramped up this particular thing, where a drug safety warning came out 2 years ago for the use of testosterone. All of a sudden, everybody is afraid of this stuff, therefore, and should I use it, should I not? And it really sort of continued to throw more gas on the fire. Now that's in spite of the fact that many people that have been doing lots of testosterone research had this idea, said, all our data suggests that it's helpful. That in fact, here in these Mayo Clinic proceedings, they show that higher levels of testosterone appears to be protective against these various risks. And so, it feels like it's a good thing, and yet this article was saying it's a bad thing, and it continued to add to the confusion here. Okay, just a couple of months ago, this particular study came out. And this shows actually that testosterone therapy, adjuvant testosterone therapy, may indeed be increasing the coronary artery, non-calcified coronary artery plaque volume. Now, when they actually did the studies, when they went back and compared the analysis on the statin drug studies, they went back and they were able to show that if you take a statin or don't take a statin, they set the statistical analysis such that they got enough data, and again, I'm not a statistical expert, but they got the data such that in the statin studies, they dialed it down to a 14 to 15 cubic millimeter difference in terms of plaque volume. So these guys, with this particular testosterone study, said, we're going to try to even one-up them. We're going to do a little bit better. We're going to dial it down and get enough power in this study that we can detect a 12 cubic millimeter difference. So the statistics are very good on this study. There seems to definitely be a slight increase in plaque formation, non-calcified plaque formation, that has just recently been reported. There, in this same study, is no increased CV events, though. So I just allow you to draw your own conclusions. I mean, I'm telling you data. I'm not telling you I know the exact final answer. I don't think we do know the final answer, but that's interesting data to me. Testosterone therapy there's 7 big randomized trials on testosterone therapy and a bunch of data that's delivered or received from this. But basically, when you look at the data, depending on who's reporting it and who's stating it, some people will say that there's a modest improvement in physical function and vitality, and there's improvement in sexual function. This particular reference uses those words. I'm going to flash ahead to another study by this guy, and this is actually, he used and took the exact same data, the exact same study is reported, and when he dialed it down, he said that in terms of sexual function, 42% of the men had improvement in sexual function in the early part of the study, but that had waned and pretty much trickled out later in the study, so it really wasn't there. And so that's the part in the first guy's paper, he says, rah, rah, rah for it, and this other guy says, not such a good deal. So anyway, it's just interesting seeing who is spinning this data as to what you want to get out of it. And I think that sort of sums up a lot of the testosterone issues, is that the statistics, you can turn it into kind of what you want, but even the same exact articles were quoted in 2 different people, and you got a very different flavor and feel of whether it's to be supportive or against therapy. Just quickly, is there any benefit in your brain from testosterone? Do you get better cognition, et cetera? The data would say no. When they actually have them do things like visual recall and paragraph recall and all these kind of memory tests, the data was equal. So just basics on how we test testosterone. You know, traditionally it's an AM test. There is a pulsatile secretion of testosterone, and so it's most accurate to always be comparing apples to apples, and therefore that's why you test in the morning time period. And then it's ideally best to try to get a second sample and verify that at some point, and even with an LH if possible. Now, that said, is there chapter and verse data to say a certain testosterone level is treatable or a certain testosterone level is substantial? And there's not. And so insurance companies that give you grief and say, you know, we won't cover it unless their level is 250, 300, 350, you know, whatever it is. I mean, they have no leg to stand on either. And so it's an interesting battle that they quote these things, and yet when you really pin them to the fire, and this is part of why I wanted to do this talk, is what does the data say? You know what? The data leaves you kind of confused, frankly, and I think that's worthy that we all kind of recognize that. Anyway, you test it in the morning, and I said the stuff about insurance, and boom. Okay, so anyway, just a couple of things also about free, total, et cetera. Okay, SHBG is a big glycoprotein, and it's just like glue. It sucks up testosterone, okay? And that gives you your bound or protein-bound portion of testosterone. And that's such a big molecule, it can't really enter the cells and get on to do its thing on the receptor. Albumin also binds testosterone, but albumin-bound testosterone can get into the cell. It's small enough, it's still bioavailable. So non-bound plus albumin-bound testosterone is the component that makes up the bioavailable testosterone. And I gave the size of these proteins and whatnot, but anyway, you can see that the binding hormone is affected by all these kind of chronic diseases. So if you kind of be thinking of a patient that is having trouble in those kind of chronic conditions, chances are that may be part of the reason they're having difficulties with their testosterone level. Now, if you look at some of the, what I would call natural solutions for testosterone, you know, trying to control some of those chronic diseases is obviously one of the things. Physical activity can help. There's a study here that shows, you know, the obese patients, they get out and they're active, their levels actually rise. If you don't sleep enough, that's bad. That's bad for me. I'm sure I don't sleep enough. I think probably most of us fall there. Sleep apnea, you know, I mean, most of our sleep apnea patients are obese, so that we already know is kind of a factor that can lead to it. But interestingly, unique about sleep apnea is that, you know, patients often do worse with a lot of testosterone if they have sleep apnea. It's not an absolute contraindication, but you got to be really careful with it. There's studies that confirm that. Testosterone replacements. I'm going to talk about a couple of little treatment options, and you know, so let's talk about what would every patient like? They'd like a pill. Pills are dangerous. They have poor bioavailability. There's some of the forms of the pills that actually have not only liver toxicity, they sometimes induce liver malignancy. So, you know, I use those words with patients that really push me for pills. It scares them, and usually they don't ask for another few years. Injections. Most of the time we see the cypionate used. The undecanoate version is really a long acting sort of thing, which that sounds really super convenient, you know, don't have to give it so often, that's got to be great. There's always a head to the tails on the coin, and the tails on this puppy is that, you know, pulmonary oil microembolisms and a lot of pulmonary problems are not uncommon with that form of testosterone. So anyway, you got to follow their levels if you're using injections. One thing about injections is that if a patient is having difficulties with elevated blood counts, if their crits are high and they're having that kind of thing, polycythemia issues are much more common with injection therapy than any other form of testosterone therapy. Patches, when they came out, oh man, this is going to be great. We don't have to give needles and stick people anymore. It took about, you know, a year for that to wear off because people were spending more on dermatitis, you know, prescriptions than patches. Gels, pretty easy to use, variable absorption rates. And transference is always a concern. People, you know, if you rub up against your spouse, your kids, or whatnot, people sometimes are concerned about that. You can put some stuff under your lip and cheek, and then you can't taste anything really well for a while. I mean, there's lots of issues that are, there's pros and cons to all these sort of things. So, you know, and then there's some injectable pellets that are available that have pretty good consistency. Off-label stuff is interesting for the right patient. There's some occasional younger patients who are interested in trying to preserve their fertility. And testosterone, you know, in a lot of the clinics out here that are advertising for, you know, we can make you strong and healthy and Superman again, I'm interested to take a poll of my urologist colleagues, how many patients that they see, because I've seen quite a few, where a young guy is given testosterone to strengthen him and help him, and some even to try to help him have a baby. And son of a gun, doesn't work real well, because testosterone makes you, you know, sterile by the negative feedback. I mean, some people actually did not go to endocrinology 101, and so that's a concern. But the SERMs, clomiphene, acts at the hypothalamus and pituitary, and that can therefore raise levels and maybe stimulate it that way. So that's actually an intriguing option for the right person. Your average older patient is probably not a good option for. And then, of course, the aromatase inhibitors, which is basically an astrazole, can block the peripheral conversion of the estradiol, the testosterone to estradiol, and that can alter the levels as well. So a little bit different ways to do. HCG put in there. It's kind of pretty expensive. Not very many people use it, but it's certainly an option. Risks, I've mentioned the erythrocytosis and sleep apnea issues and that. And I also mentioned already this azoospermia thing just sort of, you know, is interesting because it's not an infrequent consult that I see people come in and they're shocked to know that their baby potential for having a baby is actually, you know, if not shot, at least probably on ice for maybe 18 to 24 months or so. So back to my initial opening here, not your father's testosterone story. It's been shown that basically nowadays most people are believing this saturation model rather than the old Huggins and Hodges androgen hypothesis. More testosterone, more cancer. In reality, the data shows that androgen concentrations vary widely at low concentrations. But at higher concentrations, higher levels, it's like the receptors become saturated. And I always, you know, Peter Fisher always teases me about my analogies, but to me, this is like trying to get your swimming suit more wet in the deep end of the swimming pool than in the shallow end of the swimming pool. You reach a max, and the receptors are kind of maxed. And so there's really, you know, once you hit that point, it may not matter. And therefore, the ultimate conclusion that's interesting to us is that the data right now is showing that there's really no difference in prostate cancer progression in testosterone-treated patients. So when I grew up doing residency, thou shalt never use testosterone in a prostate cancer patient. And we don't believe that anymore. Now, we're careful with it, and we monitor them, but we're careful with it. So I think it's an option. And that, my sons can grow beards in, like with a Valsalva maneuver, I think. They must have enough testosterone. My grandsons, I don't know about. My father's in the picture. This is our testosterone Father's Day picture. Thank you for letting me talk to you.
To introduce myself, I have nothing to disclose. I am now basically an office-based cardiologist, and I find myself in a position, much as a primary care doctor, where I see some of these therapies in the periphery that are coming along and having to decide how appropriate I think they are or aren't for my patients. And so I want to talk about just three things that have come along on the cardiology forefront in the recent time and give you my bias and some of the data to support that and see if you want to share that. The second theme through my talk is this. This is my daughter, just a comment about men's health and so forth. Men's health has a lot to do with what your children choose. And so I raised my daughter here on the East Bench, and she, flute lessons, played the piccolo, and her share of AP classes. Decided she wanted to be a cowgirl. Married a cowboy. She now lives on the ranch, and I spent this week or so ago with her doing their roundup and herding cows, and you'll find that theme through my talk. But this is my East Bench daughter that became a cowgirl. And the sad thing is, maybe not sad, but she's forever telling me, I've never been happier. You have to think about that, decide how you feel about that. Anyway, these are the three things I want to talk about. So first, the PCSK9 and lipid therapy. It might be ideal if everyone were very strict in their diet and did everything right, but the reality is most of us don't. And about the third day on one of these trips, eat anything. And most of us, perhaps at an athletic event or a weekend or at some point of weakness, we eat a lot of things that we shouldn't. So the reality is, if we want to get our cholesterol near gold, then it's not going to happen by just dietary therapy alone, and we need something else. So beyond the statins, the latest thing to emerge has been the PCSK9s. And so to emphasize the importance or the advantage of pursuing these kind of therapies, just a reminder, 1 out of every 3 deaths in the United States is due to cardiovascular disease. 1 out of 7 is from a heart attack. And for men's health issue, men's heart attacks tend to occur at about 7 years before women's do. But good news, the actual incidence of cardiovascular death is declining. And in large part, that's due to these additional therapies that are becoming available, perhaps to include these PCSK9s. So there are 2 stories that are illustrated here. Bad situation, a better situation. So on the liver are the LDL receptors, whose job it is to absorb the harmful cholesterol, the LDL. You want to increase the concentration of receptors on the surface of the liver. As it turns out, there is also a molecule called this PCSK9 that's produced in the liver, and when that gets associated with a receptor plus LDL and then is taken within the liver cell, that combination of those 3 things designates that LDL receptor for destruction, and it's not returned to the surface. And so the idea was that if you can take that PCSK9 out of the picture, which seems to be the marker for receptor destruction, then these LDL receptors will get recycled. You'll have a higher concentration of LDL receptors in the surface, and that's in fact what it does. And so the PCSK9s are a monoclonal antibody that binds this PCSK9 and making it unavailable to increase the receptors. So the main trial that just came out recently is this 4-year trial that finally showed that there is a mortality benefit in doing this. And the reason it was important that we wait till this mortality trial, because there's been a lot of good ideas with cholesterol that haven't been borne out. And for example, there have been 3 different drugs that substantially raise the HDL cholesterol. Everyone anticipated there'd be a mortality benefit, but when they went to clinical trials, there was no mortality benefit shown. So it wasn't necessarily assumed that lowering LDL cholesterol would have a mortality benefit. Previous trials showed that the drug works, it lowers LDL, but this is the drug that came out that it shows that it has a mortality benefit. Now, in this trial, they took people that were already on a statin but were judged to have not met their goal, to which they added the PCSK9 to a statin. So bear that in mind of who the patient group is. And as you can see, the criteria was an LDL greater than 70, so there are a lot of people actually had a pretty decent cholesterol to receive this therapy, and it was weighed against a placebo of just a statin in a false injection. And if you can see those numbers, the drop in LDL cholesterol, is substantial. So the LDL is here about 120, and with therapy, it dropped here to about the 50 range. So a substantial reduction. And I'll just tell you as an anecdote that if you have somebody who cannot take a statin and has an LDL cholesterol somewhere near 200, you can commonly see a drop in their LDL cholesterol from 200 down to as low as 50 or 70 with this not used with a statin. So it really is an impressive drug. And here the trial results are. You can see a separation in the line over here of the placebo versus the active drug. And what it showed was that there was a decrease in non-fatal myocardial infarction, the strokes and coronary disease was reduced, and it met the target trial results. But the number needed to treat was 75 people over 2 years. One of the good secondary outcomes was that there has been a notion that maybe you can push the cholesterol too low and perhaps do some harm. This trial addressed that because they had people whose LDL cholesterol was as low as in the teens and the 20s, and they saw no adverse outcome in those patients. And the only other comparison between the trial and the active drug was no change in the injection site irritation. But what was not demonstrated was an overall reduction in cardiovascular deaths. So they reduced MIs, but they could not, by the secondary outcome, show that there actually was an overall reduction in cardiovascular deaths. So my reaction to that is that it does work. It reduces myocardial infarctions, but not necessarily all-cause deaths, but the cost is terrific. A year's worth of drug is about $14,000, and if you've got to treat 75 people to have one improved outcome, that's a lot of money per life you're saved. And those that make those kind of calculations will say that that's about twice as expensive as is reasonable to similar therapies that produce an increase in life years saved. And again, it was shown that the worry about dropping the cholesterol into the 20s was not borne out. It turns out it's fine to do that. So the clinical use, to be determined. It's not yet in the guidelines. It's a powerful drug. It's a very expensive drug. It'll no doubt find its place, but that's to be determined what it is. The next topic. And we know what this is, besides my daughter? If you're out catching cows and you have two good cowboys, you have one catch the head, one catch the feet. But if you only have one good cowboy, you catch the feet and have to have some way to catch the head. And so this is this strange device that as the cow goes by, you drop it on its head, catches the head, then you can take care of the cow. So that's kind of my reaction to TAVR. It sounds like a crazy idea, but as long ago as 2002 was when this was first done in France, as so many things are done, and it's since been refined. And so commercially on the market are available this valve that was been used popularly until about a couple years ago. And then there's this Medtronic core valve. This valve has a disadvantage of it comes on a balloon, you have to dilate it when you're across the aortic annulus, and it pushes the old valve out of the way, but once it dilates, it's stuck. And in a beating heart, that valve is not always placed where exactly you want it to be. So with some practice, they gain some skill with that, but in large part, those that implant these have become more enthusiastic about this valve because it's self-expanding. They position it across the aortic annulus. It forces the old valve out of the way, and it's very clever in that the actual valve is slightly above the old annulus, so you don't have old scarred annulus, then a valve smashed inside of the stenotic valve, but the valve is actually slightly above the old valve, and so it creates a large or better profile that's comparable to a lot of the other artificial valves. So the question often becomes, does it work? And so they've gone through a series of trials where basically this Partner B trial was only allowed to be done and people were dead and dying, can't hurt them. And it showed some promise. Then the Partner A trial, it showed that in those that are high surgical risk, maybe it's a good idea, and they showed a good outcome in those people. Again, high surgical risk of almost 10%. But then the latest trial, this Partner 2 trial has come out, and these are people that have a pretty decent surgical probability of success, but they were allowed to have randomization to the transcatheter valve or open surgery, and what they showed was it had a very favorable outcome. They can implant the valve successfully, that the earlier risk of high cardioembolic stroke is improving, and the success technically of being able to implant the device is now very good, so much so that the surgeons who are involved in these teams have even become enthusiastic about this transcatheter approach, less so than opening chests up. These are the guidelines that are coming out this past month, and all I want to point out is that it's not just this odd idea that these invasive-prone people sneak our patients away into the cath lab and do these unspeakable things. It now is becoming really mainstream therapy, where obviously people that are high surgical risk or prohibitive risk, it's class 1 indication. Those with high surgical risk, class 1 indication for either a TAVR or a surgical valve. And now we're down to the intermediate surgical risk, where a 2B indication is for a TAVR and class 1 is still for surgical. So if you hear of your patient taken into the cardiology world and they come back with a TAVR, it really was not that they were a victim of some crazy scientific idea. It is mainstay therapy, and most of us will not be surprised if, for these low-risk patients, they too will become a candidate for a TAVR in not too distant future. Now, some may ask, well, if you've got a 50-year-old patient who's actually pretty healthy and you put in a TAVR and they outlive the valve, what's going to happen when they're 70 years old and now have a TAVR valve? Well, when they implant these valves, once in a while they don't get the valve where they want it and they can't move it, and so they have already developed a technique where they put a second valve in the same setting inside the valve where they really wanted the valve to go, and it works out just fine. So what they anticipate is when these valves wear out in the younger patients and they need a new valve when they're 70 or 80, they'll put a new TAVR inside the old TAVR and just extend that column of valve and still achieve the same hemodynamic benefit. So conclusion is, it's kind of a crazy idea, but if you're really enthusiastic about it and get a little practice with it, it actually works. You can implant a valve very successfully percutaneously. And lastly, I want to talk about the Watchman device. Up on the Grand Staircase National Monument, we come across these watering holes. There are always these signs. A great disclaimer that maybe it's not such a good idea to drink this the spring water that's up there. So cardioembolic strokes remains a very large problem. The stroke risk for younger people in AFib is not bad, but as you get older, the risk gets very high. But because of concerns about bleeding, a large number of people, as many as 50% of people who have an indication for anticoagulation are not anticoagulated. So for these people, either they endure that risk of a cardioembolic stroke or there has to be something else. In these people, when you do a transesophageal echo and you're able to see with great detail the atrial appendage, you literally can see smoke, as they call it, arising out of the atrial appendage. In many cases, you can see a thrombus and the smoke literally arising from the thrombus. And when you sample that smoke that comes off these, they find microaggregates of coagulate, and they have really demonstrated that in 90% of the cases or higher, that the cardioembolic stroke in AFib truly comes from the left atrial appendage. So the obvious solution is isolate the left atrial appendage. And so there have been two devices that have been developed. This one is the Watchman device. It's more widely known. This is the Amplatz device. And the concept is very simple. Stuff this thing into the atrial appendage so there is no longer appendage. Problem of a cardioembolic stroke solved. The trouble is this device can embolize, but more commonly, this looks pretty innocent, but there actually are some barbs on the end of those stays that grab the atrial appendage, and in the early implanters, as many as 10% had a pericardial effusion that required urgent or emergent treatment. That complication has been reduced, but there still is substantial difficulty in implanting these devices. So the trial that was done not long ago was this PROTECT AF trial. So standard non-vibrant fibrillation, warfarin versus Watchman. The goal was only non-inferiority, and so they'd implant these devices 4 to 5 days, 6 months, 12 months. They'd do a transesophageal echo, and if they could confirm that they had sealed off the appendage, then they'd go ahead and stop the warfarin, convert them to 6 months of aspirin and clopidogrel. After that, only aspirin. 90% of the time, they were able to demonstrate that the atrial appendage was isolated and able to proceed down that de-escalation pattern of anticoagulation. Interesting, their INRs weren't that good during the course of the trial for the comparison, and maybe ours are better, maybe not. So what they showed in this optimistic trial was that it was non-inferior in terms of the composite endpoint. So there was not inferior, the non-inferiority was not established for ischemic strokes, but they only made their endpoint because they gained ground in preventing bleeding. And that's kind of what you would have expected. So if your worry is, if you anticoagulate somebody, they're going to bleed. And so if you don't give them some kind of protection, they have a stroke. So it's either risk of bleeding from the warfarin, put the device in, and stop the warfarin and see if they can't prevent a stroke. So the composite endpoint of both those good outcomes was met, but purely to prevent cardioembolic stroke was not met, meaning that even though you seal off a left atrial appendage, it is still possible to have a stroke, even though that may be removed from the equation. In a follow-up trial designed to duplicate the data, their data wasn't as good. So it's kind of a borderline, did they prove it, didn't they prove it? And there are those that still kind of stand on the sidelines a little bit skeptical about this, and it hasn't been enthusiastically endorsed. Here's the current guideline for the indication of implanting a Watchman. It's only a 2B. So enthusiasm is not high, but in those patients who you judge to be at a very high risk of a cardioembolic stroke, and they just cannot take anticoagulation, it's a reasonable option. And when your hands really get grimed up with unspeakable things, you've got to have someone else put the M&Ms in your mouth. That's the other thing you learn up on the mountain. So those are the three things I hope I've introduced. PCSK9, it's expensive, it works, hasn't found its place yet. TAVR is here, it's real. We deserve to be enthusiastic about it. The Watchman, yeah, it might work, needs to be refined. More to come on that probably. Thank you.
So let's get all the speakers up front.